Vaginal Surgery Masterclass Series. Today's topic is non-descent vaginal hysterectomy. That is NDVH, indication, patient selection, and what are the step-by-step technique. Now, the agenda, what you will learn will be 1 is rationale and evidence, why NDVH matters, and how vaginal root outcome compared to abdominal laparoscopic surgery. You should know. Then what should be the patient selection for the surgery? What are the indications? What are the contraindications? What is the selection criteria? And how we do the preoperative workup. Third point will be what is the anatomy. Whenever we are doing the non-descent vaginal hysterectomy, it's our responsibility to learn every aspect of the pelvic anatomy and so that we can do the best of the surgery. So how the ligaments support uterus, what are the avascular spaces, how ureteric course relevant to NDVH. Then fourth is a step-by-step technique, how the incision, what are the ligament ligation, what are the uterine artery control, debulking, and what closure. Then facilitating the descent, traction methods, intracraniculum technique for the non-descent uterus, and what are the challenges and how the patient recover. So intraoperative problem solving, post-operative care, pitfalls and pitfalls. So why NDVH matters? NDVH extends the benefit of vaginal root to the women, those whose uterus is not descended. The majority of women needing hysterectomy for benign diseases. No abdominal incision, that's very, very important. So no laparotomy scar, no wound infection, no incisional hernia. Faster recovery as there is a no abdominal incision. So the shorter hospital stay, quicker return to the normal activity than open surgery. Lower cost of care because fewer theatre resources, shorter admission, no laparoscopic equipment is required. And skill worth preserving because the vagina is the root for the surgeon. So shrinking proportion of surgeons are trained in NDVH despite its favorable outcome. In clinical context, what is the vaginal and other root? This is a Cochrane systemic review. So many previously. The best outcome, vaginal hysterectomy, had the most favorable overall outcome. Faster recovery because activities are better quality versus abdominal hysterectomy, and shorter operating time. Because in a laparoscopic hysterectomy or abdominal hysterectomy, it needs a lot much time. So vaginal hysterectomy is a choice whenever feasible. Now, what are the indications for non-descent vaginal hysterectomy? The menstrual also, pre-malignant and adnexal. Any abnormal uterine bleeding refractive to the medical therapy are the good for the patient. Any symptomatic fibroid up to the size of 16 to 20 weeks with a debulking can be done. Adenomyosis with disabling pain or bleeding. Endometrial hyperplasia with atypia, fertility not desired. CIN, cervical dysplasia not amenable, conservative surgery. And elective sterilization combined with systematic diseases. Adnexal, chronic pelvic pain, uterine origin after workup, failed conservative or minimally invasive alternatives, and concomitant opportunistic self-injectomy can be planned along with. Now, the contraindications and red flag. Now, previously, those who are the absolute relative contraindication, but they have become the indication of non-descent hysterectomy nowadays. Absolute is a known or suspected malignancy, adnexal malignancy, pelvic infection or abscess, and uterine size grossly exceeding the debulking limit and which is immobilize the immobile pelvis. But relative severe pelvic adhesion with prior surgery, endometriosis can be done. Markedly narrow or narrow elastic vagina limiting access. Immobile uterus fixed with extensive disease and multiple prior cesarean section, not an absolute barrier, but raises the blood injury risk. And large adnexal masses require separate evaluation. So criteria is size of the uterus, ideally less than 280 grams, 12-week size, up to 60 to 80 can be done and visible with debulking techniques and experienced hands. Mobility, under anesthesia, cervix should be drawn at least mid-vagina and single most predictive factor for success. Vaginal access, adequate width, elasticity, pubic arch angle, narrow, elastic vagina limit the exposure. And the history of prior surgeries or previous cesarean section or any other surgeries raises risk, but they are not the absolute contraindication. Now, preoperative assessment, proper history and examination, detailed menstrual, surgical, obstetric history, bimanual examination, under anesthesia if needed to confirm size, mobility, and descent of the cervix. Imaging, transvaginal ultrasound to confirm size, fibroid mapping, adnexal status, MRI reserved for diagnostic uncertainty. Cervical or endometrial screening, very important, pap smear endometrial sampling for abnormal bleeding to exclude malignancy before surgery. Medical optimization, anemia correction, glycemic control, anesthesia fitness, thromboprophylaxis, and risk stratification. Informed consults discuss the root rationale, what are the conversion risks, what are the complication profile, and what are the alternative approaches. So relevant anatomy for NDVH, mastery of the vaginal hysterectomy, rests on three anatomical pillars. One is the ligament support, second is the avascular surgical places, and third is the variable course of the urine. So ligament support, we should know the uterosacral ligaments, cardinal ligaments, and third is both are clamped, cut, and ligated in sequence to the proceeding syphiliae. Avascular spaces, vesicocervical place, anterior plane between bladder and cervix, pouch of Douglas, posterior peritoneal place opened first, and the paravesical spaces developed in excess of difficulty. Ureteric course passes 1.5 to 2 centimeter lateral to the cervix, beneath the uterine artery, water under the bridge. A greater stress during the cardinal ligament and the uterine artery clamping. Stays close to the vaginal wall corners and ligature sites, clamp must be hugged the cervix. Now, anesthesia and positioning, these are the two important points for the non-distant vaginal hysterectomy. Spinal anesthesia, preferred one. General anesthesia for the anxious patient for the prolonged expected time or the contraindication for the vaginal block. Adequate muscle relaxation, vaginal access, reduce the traction effect. Now, the important one is the positioning. Dorsal lithotomy position, adequate hip flexion, and abduction for vaginal exposure. Buttocks position slightly beyond the table edge to allow the under-restricted the instrument movement. Bladder catheterized, emptied before the procedure begins. Examination under anesthesia repeated at the different type of points for the confirmation of the size, for the mobility and the descent. Now, what are the steps? Step 1 is initial circumferential incision and a bladder dissection. Grasp the cervix to tenacula, anterior and posterior, make a circumferential incision at the cervico-vaginal junction. Develop the vesicocervical space anteriorly with sharp and blunt dissection. Enter the anterior peritoneal fold once the bladder is adequately mobilized, confirmed by visualizing shiny peritoneum. Posteriorly incise and enter the pouch of Douglas, placing the finger to confirm the free peritoneal space before proceeding. Now, key point is confirm bladder is fully off the cervix before clamping the uterosacral complex to avoid cystotomy. Second is securing the uterosacral and the cardinal ligaments. Identify and clamp the uterosacral ligaments bilaterally close to the cervix. Cut and ligate with the transfixation suture. Sequentially clamp, cut and ligate the cardinal McIndore's ligament complex on each side, and progressive traction on the cervix with each ligament division brings the uterine vessel in the view. Again, the key point is clamp should be hugged to the cervix. Pedicles taken too far laterally increases the chances of ureteric injuries. Now, uterine artery ligation, clamp the uterine artery vein as a single pedicle. Cut the doubly ligated, suture ligated preferred, over a simple tie for the hemostatic security. This step usually produces the most significant hemostatic control of the entire procedure. Meticulous technique here minimizes the blood loss. Now, key point, the ureter just lies lateral to the inferior of the uterine artery, clamp medially close to the uterus. Now, the size of the uterus is big, so debulking is one of the things which we can do in a non-descended uterus. Once the uterine vessels are secured, fundus opening remains too large to deliver in time. So, debulking techniques are there to reduce the size of the volume in situ. Now, these are the techniques. First is the bisection. Uterus splits sagittally into two halves and midline under the frontal traction, each half delivered separately. It is best suited for the moderately enlarged, fairly symmetric uterus. Coring, cone-shaped core of the myometrium moved circumferentially and reduced while preserving the serosa shell. Diffusely bulky uterus, adenomatic or situ uterus, these are the coring is needed. Wedge morcellation, we have to remove the wedge size segment serially, excise from fundus, body progressively and shrink the mass. Multiple large fibroids at various sites. Then myomic SC2, individual dominant fibroids enucleated before addressing the uterine body. Discrete large pedunculated fibroids can be done. Now, fifth step is adnexal masses management and vault closure. Once the uterus is delivered, secure the uterotubulin round ligament and the fallopian tube bilaterally and proceed for the salping oophorectomy if needed. Perform opportunistic bilateral salpingectomy when ovarian conservation is planned for recurrent cancer risk reduction. Inspect the pedicles for the hemostasis, irrigate, confirm no acting bleeding from the wall. Close the vaginal wall, incorporating previously tagged uterosacrals, cardinal ligaments, pedicles into the angles for apical wall support, and if needed, the Meckel's scaldoplasty needed. Confirm bladder and ureteric integrity if concern arise during intraoperatively, methylene blue test, or if needed, cystoscopy can be done. The key point is incorporating uterosacral pedicles into the wall, into the vaginal angles, reduces the long-term wall prolapse risk. Now, these are the techniques to facilitate uterine descent: progressive tenaculum traction, fundal pressure, early uterosacral and cardinal division, and morcellation assisted delivery. Now, intraoperative challenges and solution. Poor uterine descent, what has to be done? Reapply tenaculum progressively, add fundal pressure, consider early debulking to reduce the bulk. Difficult bladder dissection, sharp dissection, incorrect the avascular plane. If scarred from the previous section, dissect laterally first, then return again to midline. Excessive bleeding from the pedicle, reclamp, religate under the direct vision rather than the blunt suturing, apply pressure and improve exposure first. Then difficulty in assessing the fundus in the bulky uterus, switch the bisection, coring progressively, shrink the mass and improve the traction. Unexpected adnexal pathology, extend assessment via open peritoneal cavity, convert into laparoscopic assistance if needed. If additions, mask preclude safe vaginal completion. Suspected bladder and ureteric injury, confirm immediately with methylene blue installation or cystoscopy. Repair primarily, involve the urologist if needed before closing. Now, after the surgeries, our responsibility to do a proper postoperative care and recovery immediately 0 to 24 hours, then 1 to 7 days and 2 to 6 weeks. Monitor vitals, bleeding, ambulation within 16 to 12 hours, catheter removal per protocol once mobile, adequate analgesia to support mobilization. From 1 to 7 days, progressive diet advancement, watch over UTI and vault, typical discharge by day 2 to 4 for uncomplicated cases, avoid heavy lifting and straining. Wall checkup for 6 weeks for healing and granulation tissue, resume normal activity gradually by 4 to 6 weeks, and pelvic rest, no intercourse, tampons until vault is fully healed up to 6 weeks. Address any dyspareunia granulation tissue at the review. Now, pearls, pitfalls, and the complication avoidance. Pearls are keep every clamp flush against the cervix, uterus to provide the ureter. Confirm bladder mobilization. Before clamping cardinal pedicles, use progressive traction. Never force non-descended uterus down. But what to avoid? Clamping pedicles too far laterally, excessive traction causing vaults, vaginal tears, and processing the debulking without confirmed hemostasis of the uterine vessels. So at the end, what are the key takeaways and a summary of non-descent vaginal hysterectomy is: number 1, NDVH extends proven vaginal root benefits, faster recovery, less complications, fewer complications, lower cost, and to women without prolapse. It succeeds and depends upon careful patient selection. Proper uterine mobility matters the most than the size alone. Master the anatomy of the ligamentous support, avascular spaces, and ureteric course before operation. Debulking techniques, bisection, coring, wedge morcellation safely extend NDVH to large uterine. And the meticulous cervix hugging patriarchal control is the single greatest safeguard against urinary tract infection. Thank you so much for the patient listening.